Welcome to Cornea Care. We are starting with a series on peripheral ulcerative keratitis. Outer 50% of cornea is considered peripheral cornea. Its pathologies can be broadly classified into infectious and non-infectious. In infectious, any microbe which can infect central cornea can affect the periphery too. Some systemic infections like TB, syphilis, gonorrhea involve peripheral cornea. Of course, the incidence of localized ocular infections is much higher than the systemic ones. In non-infectious etiologies, again we can have pathologies which can be limited to eye, as we see in Mooren's ulcer, marginal keratitis, or ocular rosacea. Systemic non-infectious causes like rheumatoid, Wegener's, or ulcerative colitis typically involve peripheral cornea. Out of these, RA-associated PUK is most commonly seen by us. But in today's talk, we will discuss only Mooren out of this large variety of PUK. Mooren ulcer starts at extreme periphery, that is limbus. It is a crescent-shaped infiltrate where the infiltrate is seen at the edge of an epithelial defect, and as the disease progresses, there is an area of stromal loss. A characteristic feature of Mooren is overhanging edge. If we touch the central edge, we realize that we can flip it as the underneath stroma has been eaten and thinning is much wider than what it appears. Most probably, it starts as patchy infiltrate at limbus, infiltrates coalesce, and then the overlying epithelium gives way. We usually see this stage only as the patient becomes symptomatic. Another characteristic feature is the way it spreads. It is slow in progression. Progress is circumferential at edges as well as central. This disease is usually seen in middle ages. More common in men, unilateral is more common than bilateral. Bilateral disease indicates a severe disease. Interpalpebral area is the most common site, though other quadrants can also be affected. Its exact etiology is not known, but all evidence hint toward the autoimmune cause. Some reports point towards association with hepatitis C. In Nigeria, people have found association with hookworm infection. But many systemic collagen vascular diseases present with similar peripheral infiltrates. That is the reason it's always a diagnosis of exclusion, and physician consultation is always taken. Whatever investigations we do, they are to rule out these systemic associations. Ideally, physicians should be very well versed with various immunosuppressants as these are required frequently. Let's see what should we do when we see a case of Mooren's. Dimensions are measured in clock hours, thinning is judged, and then we stain to see the defect. Advancing edges need to be carefully examined. Since it's a gutter, so dye is pooled. Then we use a sponge to soak the pooled dye. We do this assessment at every visit so that we know that the disease is worsening or improving. Worsening of disease is marked by increase in infiltrate size, increase in defect, and stromal melt. Signs of improvement are opposite. Defect and infiltrate start resolving and get replaced by a scar. In the absence of treatment, and sometimes despite treatment, the disease course is unpredictable and the peripheral cornea gets destroyed. Let's see other eye of this patient, in whom the right eye has typical look of resolved Mooren. The left eye has two areas of infiltrate, an upper arc-like and another at 8 o'clock. There is extensive thinning at 8 o'clock, and on staining there is defect. Extending margins of defect are very clearly visible. Upper arc-like infiltrate is not limbal in location, rather paracentral, and there are early defects. It's not limbal because the upper stroma has already been destroyed and replaced by scar. Perforations are not very common, but of course they do happen. Treatment comprises following modalities. Since it's an immune disease, steroids and immunosuppressants are the mainstay of treatment. They are employed depending upon the disease severity. Conjunctival resection is done as it is thought that the conjunctival vessels bring the inflammatory mediators. There are no guidelines for glue, but I do it when thinning is more than 70%. It serves the dual purpose. Not only the weak area is strengthened, it also creates a barrier between inflammatory mediators and the bare stroma. In resection, we go 4 mm behind limbus and 2 clock hour beyond the active disease margin. In this paper, certain guidelines have been given which help in choosing the therapy. Bilateral disease always requires systemic immunosuppression. Oral methotrexate is used as steroid-sparing agent as well as in severe disease. IV methylpred is advised when perforation is impending, and the most severe cases require IV cyclophosphamide. With this basic background, let's go through some cases. This young boy of 19 years had a history of 20 days. His current medication was mainly antibiotic. Oral steroid was biflace 3 times a day. Ulcer dimensions were measured. Conjunctival resection was done. Due to 80% thinning, glue was also applied. Baseline investigations were done after consulting physician. Betnisol was started in 6 times dose. After 19 days of treatment, IOP increased. To manage this, steroids were tapered. When this alone was not sufficient, Betnisol was stopped and anti-glaucoma medication added. Thankfully, his disease was responding well. Glue became loose after 7 weeks, so removed. Medication was stopped after 3 months. Coming to next case, where more than one quadrant was involved. In this young male, history was of 7 months, and previous treatment records revealed that initially Predfort was started, and later on when ulcer happened, he was shifted to FML. Discharge was clean before proper evaluation. In addition to conjunctival resection, glue, topical steroids and oral steroids were also added. Physician opinion was taken. He did well in the initial period. Gradually, steroids were tapered. After 2 months, discharge was noted. On cleaning, entire glue came out. And still there was significant thinning, so glue was reapplied. At 5 months follow-up, glue again became loose. There was a clean area of thinning without any infiltrate, so a localized glue was reapplied. Repeat glue in a vascular bed is a tedious task, but ultimately we were able to achieve a good outcome. Since we learn more from mistakes, now I will share 2 cases where I made some mistakes in diagnosis as well as management. I encountered this middle-aged male in 2012 who presented with history of 2 months and was already on oral steroids and had undergone few investigations. Ulcer assessment was done. Since hypopyon was there and infiltrate was not looking sterile, I wanted to take scraping first and do conjunctival resection at that time. Pathologist was not available on that day, so I just increased antibiotic and called him next day. Next day I did scraping to rule out secondary infection and applied glue. But I forgot to do conjunctival resection. Started him on topical steroids, antibiotics and lubricants on the lines of Mooren's ulcer. His inflammation decreased initially, but persistence of central stromal edema and presence of exudates on the endothelium was a bit confusing. On follow-up, steroids were gradually tapered. Large chunk of glue became loose, so it was removed. But epithelialization was extremely slow. After 40 days of presentation, he developed a large epithelial defect with scalloped margin. Importance of scalloped margin has been already discussed, but at that time I misinterpreted it to be due to a tight BCL. After 2 days when dendritic extensions were noted, then I revised my diagnosis to concurrent HSK and added ACV ointment. Now he slowly responded. But on retrospective analysis of his picture, I feel that this PUK was never a Mooren. Advancing edges were not serpiginous, infiltrate was also diffuse, and hypopyon is never present in Mooren unless secondary infection. So actually it was a viral keratitis which was misdiagnosed as Mooren with secondary infection. With revised diagnosis, we can explain so many clinical features which were earlier confusing us, that is, endoexudates, persisting central edema, slow epithelialization, epithelial defect with scalloped margin. In fact, it appears that infiltrate was never limbal in origin also. Of course, those ophthalmologists who examine these ulcers in early stages are more likely to make a right diagnosis. Now coming to last and my most challenging case. This male also had a history of 2 months. For last 40 days, he was on Getty betamethasone, earlier 6 times and later on 4 times a day, in addition to antibiotic and cyclo. On assessment, I noted that there was 70% thinning at 10 o'clock, but epithelial defect was nearly healed and edges from the two sides were about to meet. I went through other records also and labeled it as a resolving Mooren's and started steroid tapering. He initially appeared stable, so I attached him to a local referring ophthalmologist. But on 2 weeks follow-up, epithelial defect had widened and edges appeared active. Glue and conjunctival resection were explained to the patient. He got so much frightened that he vanished, to return after 2 months with a BCL over prolapsed iris. Even now, there was not much of activity at advancing edges, and it appeared that initially thinned out area at 10 o'clock has melted now. Glue application is tedious in the presence of iris prolapse, but we managed to achieve success. Oral and topical steroids were started and rheumatological opinion taken to start methotrexate. We can clearly see that edges are not looking very active at this moment. But 3 weeks later, thinning started at 7 o'clock. We continued oral steroids but made a switch to milder steroids in view of thinning. Though thinning stopped, we faced a new problem of deranged liver enzymes. Methotrexate was stopped for 2 weeks to reassess his levels. When he came after 2 weeks, loose glue was covered with discharge. This loose glue was removed and a fresh one applied. When this glue again got loose next day, we realized that our patient is undergoing rapid melt. So under rheumatological guidance, IV methylpred and IV cyclophosphamide were administered. Our miseries still continued. After 3 days, a trace hypopion appeared. I could not identify the foci of infection, but in Mooren's, hypopion means secondary infection, so topical steroids were stopped and Zymaxid 1 hourly started. Within 2 days of infection, it had spread like a wildfire, and the moment I touched it for scraping, there was perforation. It was quite apparent that the glue won't work now. Patch graft was done. We faced many hurdles in epithelialization. Both tarso and BCL were done. He kept on receiving monthly cyclophosphamide and other drugs which are given in prolonged oral steroid use. Ultimately, we were successful in salvaging this eye with reasonably good vision of 6/18 parts. My learning in Mooren is it's very unpredictable. Keep close follow-up. Many cases require prolonged immunosuppression, so a well-versed physician is must in management of Mooren's. Thanks a lot for your patient listening.